Ok, muy buenas noches. Muchas gracias por estar acá con nosotros. En nombre del CINSAN y la Universidad de los Andes, que siempre nos ha apoyado, vamos a dar inicio a uno de nuestros nuevos webinars que estamos organizando como CINS. En esta ocasión tenemos el privilegio de tener al doctor Alan Axamir, que nos va a hablar de complicaciones neurológicas del COVID-19. Estará de chairman el doctor Carlos Navarrete, que fue a su vez uno de mis maestros. Probablemente recuerden que tenemos un listado de seminarios o webinars que vienen. En las siguientes imágenes voy a poder mostrarles cuáles son los webinars que vienen. Y si no lo mostramos ahora, lo mostramos después. Le voy a dar, aquí vienen. Tenemos las complicaciones neurológicas del COVID, que es hoy día. Mañana tenemos los casos clínicos de neuroinmunología. Tendremos afasia primaria y progresiva, aproximación semiológica a los movimientos normales, neuropatía de fibra única, prevención secundaria del infarto cerebral, manejo moderno de la isquemia cerebral tardía y distonía. Esos son los que vienen por el momento, se van a ir agregando más. Dejo con ustedes entonces al doctor Carlos Navarrete, quien hará una breve introducción al doctor Alan Axon. Carlos.
Thank you. I will presume that there was sufficient introduction there that I don't need to. Disease are yet to be worked out, as I've already said. And the first question, of course, is there neuroinvasion by the virus? And there's limited information to suggest that it is. Clearly, the neurological manifestations can be prominent, but there seems to be other things that play a role. And more specifically, there seem to be the non-immunological things that have to do with drop in blood pressure and the hypoxia that's part of the pulmonary infection. And then there's the fact that there is an immunological storm that occurs, or a cytokine storm that occurs because of the infections of the lungs and other organs of the body, as well as the brain. And we can understand that there is then a maladaptive cytokine profile that develops. And there seems to be effects on the vascular system as well, leading to microvascular and macrovascular thrombosis. So when we break down the hypotheses, we can sort of parse them out so that there's disturbances in neurological function rather than neurological direct disease. There is a prothrombotic component of the vascular effects. The question is there direct infection? And we clearly know that the immunological manifestations can cause para-infectious or post-infectious phenomenon. So just to draw parallels to other forms of coronaviruses, phenomena can occur with SARS-CoV-2 that are seen with other viruses. So the anosmia, for example, is common associated with influenza or SARS-CoV-1. Acute disseminated encephalomyelitis as a post-infectious phenomenon has been observed. And again, there are other phenomena that suggest that there are parallels to the neuropathological findings that have been described with SARS-CoV-1 and the MERS coronavirus, Middle Eastern respiratory syndrome coronavirus infections as well. So we have some concern that there can be direct infection as there is with those viruses. This is from a nice review that recently appeared in JAMA Neurology, talking about the pathogenesis of CoV-2 and its effects on the brain, and showing some places where the angiotensin converting enzyme expression occurs in the brain, in the motor cortex, in the ventricles, the posterior cingulate, in the middle temporal gyrus, in the olfactory system, and in the brainstem. But if you really break it down and look at the data and look back at the information as it plays out, what we really know about the expression of this receptor is derived from investigations in mouse brain. So the human brain is not so well mapped out with regards to the specifics. So this diagram is a little bit misleading. And again, most of the data and the inferences that are made about neurological manifestations are derived from mouse experiments with this virus. I'm going to turn to the testing next, and just to introduce that. And of course, we know that there are really two kinds of testing that we do for this virus. The first is the PCR testing, which is represented in this graphic diagram as solid lines: blue in nasopharyngeal swab positivity, respiratory tract in this sort of orange curve, the pink representing the bronchoalveolar lavage or sputum PCR, and the yellow or gold is stool PCR. So those solid lines represent the presence of virus and the shedding of virus in those various organs. So the question one might ask then from a neurological viewpoint is, where is spinal fluid represented on this diagram? And the reality is we have relatively little data to make this kind of graphic representation, as the virus is harvested directly from spinal fluid or from nervous system tissue. We'll turn to serology next, and the broken lines here represent the presence, first of all, of IgM, the purple line, broken line, and then the green line, the IgG. And of course, just showing about the occurrence of the antibodies relative to the onset of the disease, usually appearing by the end of week 1 after the time of infection, and clearly lasting into several weeks or even maybe months after the infection. But then you could ask about the nervous system, and as you may remember, for many viral infections of the nervous system that directly infect the nervous system, we're often interested in the spinal fluid IgM, and we have no data about that. We really don't know about the IgM response against the virus in the central nervous system or in the spinal fluid. And another mechanism that we commonly use for viral diagnosis, at least later in the course of illness, is to do the serum versus spinal fluid IgG index, looking at the relative titers of antibodies in the serum versus the spinal fluid. And again, there really is no data about these facts. So we're really still learning and really can't make much comment about the utility of either PCR or serology in spinal fluid, though those are very much needed in helping with understanding more about the nervous system. There are other challenges, particularly in the published neuro-COVID literature, and I think it stems from this idea that there is a contrast between the pressure to publish and disseminate information. People are hungry for information. Journals are anxious to publish information about COVID-19, but have been a little bit, let's say, more lax in accepting articles regarding the quality standards and the completeness of the data sets that are submitted for publication. So we have a number of problems when we look at the literature. There's uncertainty about the clinical pathological entities that we're dealing with. There's incomplete information about the temporal profile of the neurological illnesses. It's hard to determine about the association of COVID to the neurological disease in some cases, in some of the case-controlled series. And often there's a lack of control groups in order to compare and contrast with other infections or other neurological diseases, for instance, in stroke, and stroke from other causes. And as I've already told you, there's no standardized testing to help us with the sensitivity and specificity of the spinal fluid testing for COVID-19. So trying to make our minds up about whether the disease is affecting the nervous system in a direct or an indirect way. Next, I'd like to just take you through then a survey of reported neurological manifestations. And again, this is in no way a complete survey, but I want to just touch on some highlights. So I'll start with an early paper that was published with a fairly large number of patients. This was from the Wuhan, China study. They reviewed 214 patients. 78 patients they indicated had neurological manifestations of COVID-19 infection. And if you look through the list that are listed here in red, headache, dizziness, impaired consciousness, a lot of those are rather non-specific symptoms and are associated with incomplete information as to whether this is a direct or indirect viral infection. Ataxia, again, rather non-specific. And then acute cerebrovascular disease, and we'll talk more about stroke. And epilepsy also being sometimes a manifestation, gratefully a fairly rare one. The part of the peripheral nervous system that's been focused on is the presence of both dysgeusia or trouble with taste and anosmia or trouble with smell that seems to be relatively specific for COVID-19 and helps to distinguish it from some of the other viral infections. And then problems with breakdown in skeletal muscle, which again seems to be a rather non-specific phenomenon with regards to its manifestations compared to other critical illness. So among the 78 patients that they identified with neurological disease, they found that there was that severe infection in older age was particularly associated with neurological manifestations. Despite the fact that they had 78 patients with neurological illness, only 5 had cerebrovascular disease. More had impaired consciousness, and again, the details of which are poorly outlined in the paper. And then skeletal muscle injury basically is just a measurement of muscle enzymatic elevation in the serum. So it's elevation of CK and LDH in particular. So although the neurological symptoms were relatively common in this paper, it's unclear from the paper whether they were primary due to viral invasion or secondary to hypoxic, metabolic, or pre-existent condition in this particular case. And again, most patients with stroke and depressed level of consciousness occurred later and in more severe disease. The most important missing thing, I think, in this particular paper was that there was no spinal fluid results reported. The next paper I'll share with you is one that was published in the New England Journal from the group in Strasbourg, France. They had 64 consecutive patients that were admitted to the hospital because of ARDS related to COVID-19, and 58 of them had neurological symptoms, which was interesting. But again, if you look at the specifics of the quality of the symptoms, agitation, cortical spinal tract signs, and what they called a dysexecutive syndrome, which was disorientation or difficulty with carrying out motor commands, rather non-specific symptoms of encephalopathy typically, and not very specific in order to segregate COVID infection from other causes of neurological disease. The brain MRI scan component of this paper was interesting. They did suggest that there was some patients who had MRI abnormalities, leptomeningeal enhancement, some perfusion abnormalities in some of the patients that they tested, and cerebral ischemic stroke in 3 of 13 patients who had MRI scans. However, they also did include CSF analysis from 7 patients among their group. All 7 who had spinal fluid showed no abnormality of elevation of cell count, and all 7 were tested by PCR for SARS-CoV-2 in the CSF, and all of them were negative. So it didn't seem like there was a significant number of patients who had, among all of these clinical conditions, direct infection as detected by the molecular techniques. This is just examples of the imaging studies that they published going along with the stroke and leptomeningeal enhancement abnormalities. And I'll just comment and say, I think that the findings are rather subtle and difficult to know the significance of these small, minute abnormalities to account for more generalized and severe encephalopathy findings. So I really think that the imaging is not very convincing to go along with the clinical features that they reported. So I really don't know the significance of the imaging findings in that particular paper. Next, I'll turn to a report from Italy. This was a retrospective single center cohort study They did do a little bit of a comparison. They had 56 patients who had COVID-19, and they were compared to 117 patients who did not have COVID-19. When they looked at the comparison with regards to TIA, ischemic stroke, and hemorrhagic stroke, there was similar distribution. So it suggested that stroke was not more prevalent in the COVID patients. Delirium was more common in the COVID patients. In-hospital mortality rates was higher in the COVID patients, and less of the COVID patients had good functional outcome after their hospitalization. So it suggested that there were factors that led to, again, poor outcome, in particular when COVID was present. It's unclear, again, whether it had any role in, COVID-19 had any role in producing stroke. And they did not provide any imaging data or segregation of the patients by mechanism of stroke. So again, a little bit hard to interpret with regards to going forward. So the big question from my viewpoint is, does SARS-CoV-2 cause a neuroinvasive meningoencephalitis? And at least there are a few scattered reports that tantalizingly suggest that it does. This is an example from Japan that was a 24-year-old man who presented with encephalopathy and seizures, who had a mild pleocytosis of just 12 cells per microliter in a spinal fluid, but had an elevated CSF opening pressure, and had MRI imaging, particularly in the mesial temporal lobe areas that one could see on MRI, suggesting that there was an encephalitic component that particularly had its predisposition for the temporal lobe and the hippocampal areas. That's to be juxtaposed against some of the post-mortem examination papers that have been published. This is one from Germany. They did 12 consecutive patients with COVID-19. They looked carefully for signs of encephalitis or vasculitis and did not find evidence of direct invasion or direct effects with inflammation in the central nervous system. Of course, the absence of evidence does not mean that viral invasion cannot happen. And encephalitis is probably not a common thing. So that if it does occur, it's probably an infrequent occurrence. This is another more recent publication from the group in Boston that looked at the brains of patients who died from COVID-19, 18 patients, mean age 62 years old. And they found that mainly the findings were those of hypoxic change or ischemic change, but not much to suggest direct encephalitis or specific brain changes referable to the virus. More specifically, they did not see overt signs of thrombi or vasculitis. There were rare foci of perivascular lymphocytes detected in 2 specimens and 1 patient with focal leptomeningeal inflammation, but really not much else. So they did look with PCR at brain sections from these patients, and they found that the results were equivocal. These are often difficult to interpret with regards to whether there's direct infection versus just vascular circulation when you have a PCR analysis of whole brain tissue. And they did not find by immunohistochemistry staining infection of neurons, glial or epithelial cells, endothelial cells, I'm sorry, in particular. So again, the absence of evidence does not mean that viral invasion cannot happen. And in this particular report, they provided no spinal fluid examination data to go along with these patients' findings. So, again, pieces of information that are missing. I just want to stop for a moment and talk a little bit about the neuroinvasive potential for SARS-CoV-2. And again, as we've already mentioned, angiotensin converting enzyme receptor is expressed on a wide variety of tissues: airway epithelium, lung parenchyma, vascular endothelium, kidney cells, and small intestine cells, but it's not so well studied in human brain tissue. However, there are a fair amount of studies that have been done in mice, particularly using transgenic mice and other human or coronaviruses like MERS-CoV, where you can show that when virus is given intranasally, it can enter the brain via the olfactory nerves and thereafter spread into the rest of the brain. They show that there may be invasion of the peripheral nerve terminals and then gain access to the central nervous system via a transaxonal connected route. And this has been shown for some of these coronaviruses in mice. And they did the reverse experiment where they chemically ablated the olfactory neurons, which protected mice from COVID, from coronavirus infection into the central nervous system. So there's at least tantalizing experimental evidence that it's possible that coronavirus can enter the nervous system and potentially the human nervous system. This is a paper that was quoted by a recent review, the JAMA Neurology review that I listed at the bottom of the slide, that suggested that a recent report using RNA expression databases found that ACE2 is expressed in human neurons, astrocytes, and oligodendrocytes. This paper has not yet been peer reviewed, so again, it's a still work in progress as far as what information we have. So let's turn again to another one of the complications that's been talked about a lot with COVID-19, and is COVID-19 associated with stroke? As I've already mentioned, there is a propensity towards a coagulopathy and endothelial infection. There are reports of both coagulation changes as well as endothelial infection by histology in other tissues outside of the nervous system. So can stroke occur in an unexpected way with COVID infection? And of course, the answer, at least in a few cases, is yes. This is a report from New York in 5 patients who are young, 33 to 49. However, 3 of the patients did have pre-existing diabetes, hypertension, or hyperlipidemia. And they each had large vessel stroke presenting, and authors made the point that they just had not seen patients in this age group presenting to their institution with large vessel stroke, and therefore thought it was probably related because of the temporally associated SARS-CoV-2 infection in these patients. The criticism would be that the mechanism for these large vessel infarcts is not clearly defined in these sick patients, again, with serious systemic COVID-19 infection. And it's hard to interpret the relationship mechanistically to the COVID-19 infection. What about para-infectious or post-infectious syndromes? Can those occur? And the answer is, of course, yes. Maybe one of the most dramatic ones was published in a radiological study from our colleagues in Detroit. They described a patient who was in her late 50s who had SARS-CoV-2 viral nucleic acid in a nasopharyngeal swab specimen. They did not have ability to test for the virus in the spinal fluid. And the patient presented with a severe encephalopathy with mesial temporal, again, abnormalities, and also severe changes on the flare sequences in the thalami bilaterally, with particularly hemorrhagic components in the mesial temporal areas. So this acute necrotizing encephalopathy has been reported before as a para-infectious or post-infectious phenomenon, principally in children, and has been associated with other viral infections, particularly when there is again, an immunological hyperactivity and damage to the brain as a consequence. There has been a case at Mayo that's been published. This is our single case that's been published so far, but there are many other ones that are being studied at this time. This 71-year-old man who was unexpectedly developed COVID-19 infection after he had become hospitalized for management of an underlying coronary artery disease. He was tested, was relatively asymptomatic when he was positive, and eventually had a very downhill course and had an encephalopathy, and eventually succumbed to his pulmonary disease. His pathological findings had a mixture of both vascular and parainfectious demyelinating disease, and the exact mechanism by which this both multiple infarcts, which were present in the white matter, also present in the gray matter, and also associated with demyelinating disease and acute disseminated encephalomyelitis pathological quality were present in a multifocal way. Were the mechanisms were not able to be determined on the basis of the pathology alone. There have been other publications suggesting that ADEM, or acute disseminated encephalomyelitis, has been present in patients affected by COVID-19. This is one published from Connecticut, looking at the evolution at the initial MRI scan and then a subsequent MRI scan with more widespread and blossoming of the white matter lesions, not suggestive on diffusion weighted imaging of infarcts, and again, just slightly enhancing, mildly enhancing abnormalities with some bleeding found in the spinal fluid with xanthochromia. The mechanism for the intraventricular hemorrhage component in this particular case, completely unexplained as far as I can see. So again, some have suggested that this might be more ischemic, more than demyelinating, but there, as I said, the possibility that there's both ischemic and demyelinating features that can occur. I'll just run through a variety of neuroradiological findings that were, again, just recently published from France, appearing in the journal Radiology, showing the spectrum of the central nervous system radiological features. This is examples in their cases that they found 4 patients who had extensive and confluent supratentorial white matter disease and flare hyperintensities. There were 2 patients who had lesions involving the middle cerebellar peduncle that looked somewhat demyelinating in quality, or ADEM-like in their series. They also had 2 patients who had acute necrotizing encephalopathy with bithalamic involvement, again, with increased signal in those structures. They had at least 16 patients who had mesial temporal involvement on the flare sequences with diffusion hyperintensity, also noted in the mesial temporal areas. So again, whether this is a direct infection or whether this is a para-infectious inflammatory disorder, that has been observed. And then there were patients who had what looked like extensive and isolated white matter microhemorrhages throughout both cerebral hemispheres, as seen on these GRE sequences from that publication. So the mechanism was totally unclear as to why these patients had a microvasculopathy with hemorrhage, and particularly affecting the white matter, speculating that it might be an acute hemorrhagic leukoencephalitis type occurrence, but again, not so clear. There were patients who had other signs of involvement of white matter that in relatively unusual patterns, sort of multifocal demyelination involving the cerebellum and the brainstem in this example, but also the corpus callosum in a multifocal way as well, with some partial enhancement of some of those lesions. So again, are these infectious or are these para-infectious? Again, the temporal association with the COVID-19 viral infection is a little unclear, and the viral microbiological studies are incomplete. I'll now turn to some of the peripheral nervous system involvement. There have been a number of publications now that have shown that there is a Guillain-Barré-like illness or an acute inflammatory polyradiculoneuropathy in patients who associated with COVID-19, which may follow in an interval of 5 to 10 days between the time of the onset of the viral illness and the first neurological symptoms. This is just a publication from Italy. There's one below it from Shanghai in China, and there are a variety of other publications. And to sum those up, again, the assumption is that these are para-infectious or post-infectious phenomenon. Doesn't seem to be associated with direct nerve infection by the virus. And there are findings on the electrophysiology that suggest both axonal and demyelinating possibilities as the pathology of the disease. So next, I'll turn to the spinal cord and ask the question: can SARS-CoV-2 infection cause an acute myelitis? And the answer again is yes. So there have been rare cases of patients who present with a transverse myelitis after the COVID-19. This is a publication from Germany, and again showing that a multifocal myelitis can occur. This seemed to be based on the temporal profile, principally a post-infectious phenomenon. And again, another case from Wuhan, China, with myelitis and a sensory level with paraplegia. So there does seem to be the possibility of a para-infectious or post-infectious myelitis complicating SARS-CoV-2. And to turn back to the original publication, again, a number of other publications have come out to suggest that patients can have higher creatine kinase and lactate dehydrogenase levels, suggesting muscle breakdown. But again, it's, I think, difficult to know, although it's plausible that there is direct infection of the muscle because of the ACE receptor being expressed in endothelial cells of muscle. It's hard, I think, to distinguish based on the clinical information published whether this is just critical care myopathy or whether it's due to a direct viral infection. And we really don't have much in the way of muscle pathology studies in order to try to sort that out in a more effective way. I'll turn next to the anosmia, which has been associated with COVID-19 and thought to be a fairly specific symptom associated with COVID-19 infection. This is just an interesting publication from University of California, San Diego, here in the United States, that looked early on in the course of COVID-19, and they collected 1,400 patients with an influenza-like syndrome, and they did COVID testing, and they were able to segregate and find 59 cases of COVID positive patients, and compare those to 203 patients who did not have COVID-19. And they found that smell and taste loss were much more common, 68% and 71% respectively, as compared to 16% and 17% of the COVID negative patients. So it seems that this seems to be a rather specific symptom associated with COVID-19, although not exclusively, because other viruses can affect the respiratory epithelium. The question then becomes, what's the mechanism by which the anosmia is produced? And the answer is not clear. But anosmia is relatively common and specific. And in this particular study, they followed a subset of their patients, and when they looked at the COVID-19 related olfactory symptoms, they found that the patients often recovered within a week or two of their viral clearance. And so they assumed this is too fast for a direct nerve infection, and rather it's a suggestion that it targets the olfactory epithelium. And there's at least experimental evidence to support that notion, because the olfactory sensory neurons do not seem to express the two key genes that are involved in COVID-19 direct infection. But the olfactory epithelial support cells do express both genes in the nasal respiratory epithelium. So it's more plausible that the respiratory epithelium, rather than the direct olfactory neurons, are the mechanism for the anosmia. Still, there is this possibility of olfactory transsynaptic spread. And again, that's emphasized in this recent review from the JAMA Neurology. It's plausible because, again, as I've already shared with you, that other coronaviruses, particularly in mice, can affect the nervous system and be spread through the olfactory system to the brain in that circumstance. And in humans, at least, it's plausible, and maybe suggested by this particular case, which is a magnetic resonance imaging change that occurred in the orbital frontal area, the olfactory area of the frontal lobe, where you can see increased signal in this particular patient's frontal lobes. The serial MRI scan showed that the abnormalities cleared in 28 days, so it was thought that this was not an infarct, and it was thought that this might be a mechanism for encephalitis, but in this particular case, again, no spinal fluid was collected, so we just don't have that information to further be confident about that. So I'll conclude here. I'll just leave some time for questions, but I want to just summarize by saying the neurological manifestations are relatively rare with COVID-19. Multiple levels of the nervous system can be affected indirectly or directly. Encephalopathy, stroke, and acute disseminated encephalomyelitis seem to be the most common effects on the brain. At the spinal cord level, acute myelitis can occur, which is presumed para-infectious at this point. In the peripheral nervous system, acute inflammatory demyelinating polyradiculoneuropathy is a well-described now manifestation. Anosmia is the most common cranial nerve involvement, and possibly rhabdomyolysis, or at least a mild myopathy, can occur associated with this infection. The mechanisms of many of these diseases are not yet fully defined, and we're hoping that we'll be learning more about that in the foreseeable future. So I'll just share with you a picture of what the latest in Mayo COVID-19 personal protection equipment is about. So this is the best for brain, is the point. So thank you for your attention. I appreciate your interest, and I'm glad to take questions at this time.
Well, thank you, Dr. Aksamit. Can you hear me?
I can hear you very well. Thank you.
Okay, thanks. That helmet was really, really nice.
It's good for the brain, protects the brain very well.
Yeah, sure, but not from the virus.
Not from the virus.
So we do have very interesting questions. I'm going to start now with some of the questions are in English, so I don't have to translate, but some of them are in Spanish. So the first question is, do you think the patient with chronic disease or chronic conditions as epilepsy or even mild dementia or Parkinson's disease, etc., can get worse during the infection of COVID, or maybe after they recover? What do you think of? What do you think about? What have you seen?
Sure. There's very little data in order to bring to bear on that question. So thanks for the question. It's a very interesting one, and obviously an important one for neurologists who care for chronically ill, neurologically diseased patients. There have been a few studies that have looked at multiple sclerosis, for example, to see whether there are exacerbations of multiple sclerosis associated with COVID-19. And again, the data is mixed about that. For these other disorders, I think that obviously anoxic encephalopathy or microvascular disease, if it occurs just as a consequence of the COVID pulmonary infection, clearly can't do the brain any favors associated with these chronic neurological conditions. So a simple answer is, I think that there's likely to be long-term manifestations, but I think it's speculative at this point.
Bueno, escucharon la pregunta, pero básicamente es difícil responder. En este momento hay poca información y está el elemento de hipoxia y de isquemia de estos pacientes que usualmente graves están en UCI. Y por lo tanto, él piensa que sí estos pacientes se descompensan, tanto en la UCI como después probablemente van a estar más graves, pero no puede asegurarlo 100%, pero él cree que sí. Esta pregunta la hizo la doctora Paula Safi, y ella misma también hace la segunda pregunta. ¿Es posible, Dr. Aksamit, do you think those patients who are already with the infection in the hospital as in inpatients, but they had to have a procedure, for example, surgery for an aneurysma or coiling for an aneurysma. What is your recommendation for those procedures?
So if I understand the question correctly, is it they have COVID active infection at the time, and then they
Yes.
have other urgent or emergent
Yes.
surgical or other needs.
Yeah, you get it perfect.
Yeah, I think that it's a challenge, obviously, and I think that you have to balance the risks and benefits in the individual patients and make an individual judgment for that particular patient. But I think that there are ways to potentially both deal with containment of the COVID infection. And again, this is more of a respiratory question than it is a neurological one, and still carry out, let's say, urgent or emergent surgeries as needed.
Thank you. Bueno, dice que hay que poner las cosas sobre la balanza y obviamente frente a una situación atentatoria contra la vida, y como estos pacientes a veces tienen que someterse a anestesia y requerir la parte respiratoria, la función respiratoria es fundamental para poder decidir un procedimiento así. Dr. Joanna, I don't know the surname, asked for, this is an English question, that can paroxystic atrial fibrillation be related to cases of stroke in COVID-19 patients, especially when patients are young with less or none cerebrovascular risk factors?
So thank you again for the question. I think it's, again, going to be difficult to answer on the basis of any data, simply because we just don't have longitudinal follow-up sufficient to make a clear statement about it. But again, any patients generally who have meningitis or encephalitis, or who have white matter disease associated with acute disseminated encephalomyelitis, have long-term consequences, and specifically persistent or abnormal brain atrophy as a consequence of those diseases.
Okay, thank you. De nuevo, es bien difícil saberlo si es un epifenómeno o es una consecuencia en realidad de la enfermedad. El Dr. Mario Rivera asked for, what is the average duration for the anosmia?
Ah, great question. So it depends simply on the severity of the patient's disease. It turns out that most patients who are complaining, or at least have been reported to complain of anosmia, are usually less severely affected by the virus, and therefore they complain about the anosmia and the dysgeusia, but they often have recovery within 7 to 14 days after the onset of the clearing of the viral syndrome. So once the viral syndrome clears, they can usually clear up the other anosmia symptoms within 7 to 14 days.
Cuando se terminan los síntomas, la anosmia se recupera entre 7 y 14 días. Joanna asked a question very good here. Is there any evidence that early treatment with IV steroids may reduce neurological complications in COVID-19 patients? That's a hard one.
Yeah, again, one that there is almost no data about in order to answer the question. You probably know about the controversies of using steroids for the pulmonary disease, but there are multiple reports in the acute disseminated encephalomyelitis cases that patients at least have been treated with methylprednisolone or other high-dose steroid treatments because of their neurological disease. Whether that's made things worse or had a strong influence on improving patients faster is really impossible to discern from single case or small series reports, which is all that we have to go on.
Ok, dice que la pregunta respecto a si se podía usar dosis de corticoides endovenosos al inicio mejoraba el pronóstico neurológico de los pacientes COVID cuando tenían compromiso, y él responde que es imposible saberlo. Dice que hay reportes anecdóticos de casos de pacientes tratados pensando que es un trastorno inflamatorio, pero que es imposible recomendarlo en este momento. Tiene que verse caso a caso. Paloma Reyes says, thank you, doctor. And Gonzalo Alfaro, please, your question, make it again. Haz de nuevo la consulta, Gonzalo Alfaro, porque quedó a media. When patients present with CNS compromise, like encephalitis, impaired consciousness, seizures, what are their recommended exams to perform, Professor Axamit? MRI, vascular study, PCR in the CSF? This question is anonymous.
So thank you. Thank you again for the question. I think that it's useful to have as much data in order to design a personalized treatment for the individual patients. So simple answer is, I think MRI would be the minimum. Spinal fluid surely would be indicated with neurological compromise if it can be arranged. And again, patients who have severe respiratory failure associated with their COVID lung infections, people on ECMO and other more, let's say, intensive treatment, the spinal tap is often difficult, but EEG monitoring is important for patients who have seizures as well. So simple answer is do as much as you can.
Dice que la respuesta simple es tratar de hacer lo más que se pueda. Es difícil en pacientes que están intubados, falla respiratoria severa, llevarlos a resonancia o hacerles una PL, pero que si podemos hacerla, hay que hacerla, y que por supuesto usemos el EEG, el monitoreo EEG, tanto como se pueda. Dr. Mireya Ballard asked for, if you have in your clinic an outpatient that come to see you with a peripheral facial palsy, just that, only that, unilateral peripheral facial palsy, without any other symptom, do you ask for a COVID PCR in that moment?
So at this moment, yes, thank you. I'm not aware of isolated facial nerve palsy being associated as a clear clinical manifestation of COVID-19. Anything is, we're still learning, so I won't say it's outside of the realm of possibilities, but simple answer is I would probably not test that patient for COVID-19 with that isolated syndrome alone.
Well, Dr. Ballard knows English, so no translation.
Thank you.
There is any evidence or report, case report of start with an MS, I mean multiple sclerosis, start with the infection by COVID-19 that you're aware of?
I'm not aware of a relapsing remitting syndrome associated with initiation by COVID-19. Of course, there are patients who have MS who are affected by COVID-19. And again, the data is still yet to be, I think, mature.
Can you expand your answer, including what you said about the infection by COVID in MS patients?
So again, I do not think that there is data to support the notion that MS is initiated by COVID-19 infection.
Yeah.
It's, again, plausible because many viral infections, it's thought, can potentially predispose people who are predisposed to multiple sclerosis as a trigger for their disease. But a simple answer is there's just not data about it to answer the question directly.
Francisca Sandoval dice que no hay datos suficientes para decir eso. She also asked for if there is any relationship between the severeness of, in severe infection by COVID-19 and the neurological complications you presented before. For example, patients who are with the severe pneumonia or shock, or they can present also in patients who are oligosymptomatic as well.
So if I'm understanding the question correctly, patients who have COVID-19 who have more severe pulmonary infection, are they more prone to neurological complications? If I'm understanding that, I'm just restating the question. And the answer, of course, is yes. The patients have more encephalopathy, have more in the way of seizures, other kinds of neurological consequences, these stroke-like phenomenon on MRI. So simple answer is yes.
Yes, but have you seen patients with little symptoms or asymptomatic who did have neurological complications?
Yes. So there saw a patient last week who had COVID-19, had it relatively mild, did have malaise, fever, was incapacitated with a flu-like illness for a couple of weeks, did not have any frank neurological symptoms, but then later had a headache syndrome, went to his local physician, had an MRI scan, and had multifocal demyelinating lesions involving the periventricular white matter, and presumably had a mild form of acute disseminated encephalomyelitis as a consequence. So it's possible, I think, to even have some neurological manifestations in rare circumstances of COVID-19 and not have very much in the way of severe neurological symptoms or recognizable neurological symptoms.
Okay, thank you. I'm going to move on because we had too many questions. Could you tell us how long does the COVID-19 delirium last?
Yes.
It seems to last more than delirium caused for other conditions.
Yeah. Thank you for the question. Yes, it seems that there are. It is longer than most other delirium, just on the basis of the hypoxia or the low oxygen levels would suggest. So people do seem to have more prolonged encephalopathy as a consequence of COVID infection. Again, the mechanisms that play a role in that prolonged encephalopathy or delirium are still uncertain. And again, whether this is ischemia, whether it's demyelinating disease, whether it's a vasculopathy or microvascular disorder, all of those are still possibilities, and we don't have clear answers about, don't have sufficient numbers of pathological studies to answer the question.
Okay, la respuesta es sí. Bueno, tú hablas inglés, pero el resto la respuesta es sí, pero también nuevamente surge la duda es en qué medida esto está influenciado más por factores respiratorios y circulatorios y de hipoxia. Dr. Nicholas Rebolledo asked for in this condition of encephalopathy after COVID infection, is there any drug that you can recommend, any medication?
Yeah, so to my knowledge, there has been no successful treatment for the encephalopathy. So many things are being tried. I'm not aware the remdesivir, which is again principally directed at trying to limit severe pulmonary complications, has had any positive effect on the neurological complications, but I'm not sure how well it's been studied. So a simple answer is I think we're again dealing with a paucity of information.
Bueno, no hay medicamentos o drogas que no sean útiles en encefalopatía. Susana Lara asked for in the severe forms of COVID-19, they do evolve with a myopathy, ICU myopathy or ICU polyneuropathy. This is more severe or more frequent than in other conditions.
So simple answer is it's unknown. Again, patients are critically ill with COVID-19. And again, there are few studies that have actually done adequate comparison of people of similar critical illness to those who are affected by COVID-19 to answer that question that COVID-19 is the principal factor in causing it, as opposed to just being critically ill in the ICU care.
Yes, I just realized that. Can you open the question and answers icon there?
Can I? I can sure try. Yeah. Yes, I can.
So go down to the question from Alejandra Urra. That's the order we are now. It's in English. Go down. Alejandra Urra. URRA.
Got it. Thank you. So thank you much for your presentation. Do you think that the patients infected by COVID-19 that have been in the ICU with mechanical ventilation have more delirium versus other pathologies in the ICU? Is there a recommendation for the treatment? And again, I guess my answer is very similar. The treatment is not specific. There is clearly more encephalopathy associated with COVID-19 than just can be fully explained on the basis of the hypoxia that's present as a consequence of the pulmonary infection, but I think the mechanisms remain uncertain and the treatment remains very much up in the air. I don't think that there's clear statements that we can make. Again, if I was faced with a patient who was encephalopathic, who had MRI imaging that was suggestive of an acute disseminated encephalomyelitis, I probably would use steroids in that circumstance. And certainly there are examples of that in the literature.
Thank you. Next question is in Spanish, so I'm going to translate it for you. This is, if you have a patient with the COVID-19 disease, severe pneumonia, but you have to treat them like, for example, an NMO, this spectrum disorder, and you have to put in on steroids, for example, methylprednisolone, 1 gram VI. So what do you recommend in that case? Can we treat these patients that are in the actual infection? Do we have to wait for the recovery? How long do you expect? How do you wait? How long do you wait after the recovery? That's the question essentially.
Thank you. Again, I would probably say there's no data upon which to make this this opinion, but the opinion would be, from my viewpoint, that you wait until there's viral clearance. So if the patient has resolved shedding virus, then they should be safe to be treated with immune therapy, like steroids in particular.
Hay que esperar que la PCR sea negativa. Y no dijo nada de los anticuerpos, pero si la PCR es negativa, hay que esperar después de eso para tratarlo. Another question in Spanish is how long you have to wait until the headache resume in a COVID infection?
If I understand the question right, it's asking how long to wait until how long do you have to wait until the headache clears after COVID infection?
Sorry,
no, it's okay. The answer is it can be persistent for many months. This is true for many forms of encephalitis and encephalopathy as well that are due to other infections. So headache is often a persistent problem that can go on for months after an acute infection. So I think months is possible.
Bueno, dice que meses a veces. Next question is in English, doctor. So, Eduardo Cavieres.
Have you ever seen any neuropsychological impairment in patients after COVID-19 infection? And the answer is a handful, yes. Whether those patients had more severe neurological infection is unclear. Again, we are sort of anticipating that we will be seeing many patients who will be complaining about post-COVID neurological consequences and, again, non-specific neurocognitive symptoms of impaired memory or poor concentration and other non-specific things, as we see with other forms of infection, encephalitis and encephalopathy after infection.
Okay, the next one is, well, it's about the same. So
Yes.
Nicholas Earl was in North America studying, so he speaks in English very well, but he asked for what is the value of positive PCR for COVID-19 in CSF?
So again, there's not standardization of the assay, and so there is no single, let's say, gold standard that I can tell you. Even in our own institution, we do the PCR for spinal fluid, but we do not exactly know the sensitivity for how many copies it can find. There are what's called spiking experiments that are done in the laboratory that say it detects a certain copy level based on those sort of artificial circumstances, but precisely its sensitivity is not well determined. So I can't give you a threshold to say that there's a certain threshold that can be detected based on data.
Okay, thank you. Bueno, dijo que no estaba estandarizado. Dr. Prudencio Lozano in Spanish asked for, is there any, how important is the oligoclonal bands determination? I mean, if they are positive in a patient with COVID, so you can say there is probably a compromise for the virus, or maybe it's in a specific.
Right. So again, great question. Again, there's no data upon which to make an answer. The presence of bands by themselves are rather non-specific, and always, again, you have to make the adjustment for whether it's an intrathecal synthesis of bands or not. But simple answers, we don't know their significance, and I don't think that necessarily it would change treatment at this point, or even predict that the patient has ADEM at this point. So I think the presence of oligoclonal bands by themselves are of uncertain significance, and again, we just don't have enough data upon which to make a conclusion about the presence or absence of antibodies in the spinal fluid against COVID-19 itself.
Okay, you can read the next question. It's in English.
Sure, thank you. Have you seen a patient with post-COVID encephalitis 2 to 3 weeks later that could be explained by COVID-triggered autoimmune encephalitis? So I think this asks the question about is there an autoimmune encephalitis like NMDA receptor encephalitis after herpes simplex? And the simple answer is I don't know. But some of the images that I showed with the mesial temporal increased signal involving the temporal lobes is tantalizingly speculative that might be a para-infectious autoimmune phenomenon or post-infectious autoimmune phenomenon directed against the temporal lobe itself. But simple answer is I don't know. But it's certainly, I don't know of cases, I'll just say it, from our laboratory that have been able to identify NMDA antibodies or other paraneoplastic type antibodies that are typically associated with some of the other autoimmune encephalopathies after COVID yet. But it's intriguing to ask the question.
So we have many questions, but little answers. I guess you are, as the Mayo Clinic usually does, you are doing now studies trying to answer these questions.
Yes.
Ongoing studies.
Yes, sir. There's a collaborative effort going on between laboratory medicine, our neurohospitalists, our neurointensive care unit folks, and then myself in the outpatient area to try to answer some of these questions. Again, the severe cases are principally seen by my hospitalist colleagues, but the post-infectious phenomenon and the outpatient consequences, long-term consequences, we're trying to collaborate in the outpatient department to try to answer those questions too.
This last little question, Dr. Valar asked for, if you show the curve in time of the positive PCR in the patient, that you think the patient what showed persistent positive PCR for the virus in time maybe have more risk of neurological complications? Or
it's a great question, and I don't know how to answer it because, again, there's very little data upon which to make that conclusion. So in general, one would sort of speculate that that's true, because again, patients who are most severely affected from a pulmonary perspective are most likely to have some of the neurologic complications, the encephalopathy in particular.
well, we have a lot of thank yous for you, Dr. Aksamit, from the people who attend to your lecture.
Well, thank you for inviting me.
You are such a nice person, so maybe if you agree, we're going to bother you with some cases. We have some difficult cases in our hospital, and I'm aware that Jorge Villacura already showed you a case we had with a, I don't know, encephalitis or something like vasculitis. I don't know if you remember that case, but
I do.
But we have many cases, and I tell les digo a ustedes que si tienen algún caso y quieren mandárselo, por favor, él está dispuesto a ayudar si tienen algún caso para preguntarle en el futuro a su correo. I was wondering, I was telling the people who attend that they can ask for you for help in case they have a difficult case involved in this situation. Do you agree with that?
I'm okay with that.
Okay.
Yes, thank you.
No, thank you. Now I'm going to leave you with Jorge Villacura, who is our boss here. So thank you very much, and I hope to have you here in Santiago sooner than later after this pandemic. And thank you very much, Dr. Aksamit.
It was a great pleasure participating with you today, and again, I look forward to an opportunity to come to Santiago again.
Thank you very much, Professor Aksamit. It was a great presentation. We hope we can have you again in another webinar. Thank you very much, Carlos. You were a great chairman of this webinar. Y muchas gracias a todos los participantes. Les recuerdo entonces que mañana tenemos a esta misma hora el webinar de casos de clínicos de neuroinmunología con el doctor Flanagan. Va a estar muy bueno y nuevamente las gracias y que tengan unas muy buenas noches.